There was a lecture from 9 to 10?
No,
You were
we
free?
had from 8 to 9. Yes.
That's right.
Assalamualaikum warahmatullahi wabarakatuh. Please sit down. Boys, please have a seat. So today is the last lecture of endocrinology and it's about the calcium metabolism. So we are going to learn what is the role of calcium in the body and how it is distributed in different compartments, and what is the role of hormones in regulation of calcium, and what are the signs and symptoms of hypo and hypercalcemia. So this picture, this slide is just, no need to memorize the numbers, it is just giving you the concept how calcium is distributed. 99% of the calcium is present in the bones and remaining 1% is distributed in the soft tissues and the plasma. And plasma, you can see it having only very minute amount, 0.1%. And in the plasma, the calcium is present in two forms. One is the free ionized form of the calcium, and it is the one which is biologically active. And the other form of the calcium is the bound form, which is non-diffusible and it is not active. And this is also giving the same concept about the plasma distribution of calcium, that half of it, 50% is present as free calcium form, whereas remaining half is in the bound form, in which major portion is bound to the proteins, whereas less amount, only 10% is bound with the other ions such as phosphate ion and bicarbonate or citrate ions. So no need to memorize those numbers, just to give you the concept. So only the free form of the calcium is biologically active and it is subject to regulation. So what are the functions of the blood calcium? You have studied in the previous units. It has a role in neuromuscular excitability, and the relationship between calcium and neuromuscular excitability is inverse. If plasma calcium levels are low, neuromuscular excitability will be high. And if plasma calcium levels are high, then neuromuscular excitability will be low. So the disorders of hypocalcemia and hypercalcemia, they are related to the, you will find the clinical features of the sign of the hypo and hypercalcemia. You might have done in the clinical skills lab the short sticks test. Short sticks test. You know what is short sticks? Short stick. Yeah. When you tap, what are you tapping here? Facial nerve in front of your ear. So when you tap the facial nerve, just like tapping, what are you looking for in the patient? The contraction of what? Facial muscles, because facial nerve supplies your lips, muscles of the nose and the eyes. So when you slightly tap, you look for twitching or contractions in the facial muscles, and if the patient is having hypocalcemia, he is having low calcium levels, then you will be able to see the twitchings with just slight tap, because hypocalcemia increases the neuromuscular excitability.
Is it because it decreases the hypopolarization?
It affects the calcium ions in the blood. They are affecting the voltage gated sodium channels, because you have studied in neuromuscular physiology that action potential depolarization phase, it starts when the resting membrane potential reaches a threshold, and it is at this threshold level the voltage gated sodium channels open. Okay, so if calcium ions are there, they keep the sodium, they make it difficult for the sodium channels to gates to open. But if the calcium levels are low, then it is easier for the voltage gated sodium channels to open. So now they can open even at a lower threshold.
Because outside there are positive ions, making it seem more polar inside. If there's no calcium, it's closer to the central.
If there is no calcium outside, then the voltage gated sodium channels can open easily. So sodium will rush inward, so membrane will action potential will start. Yes?
We take in CVS, there's more calcium, there's more contraction.
So in the muscles.
Yeah, we will come to this point. We will discuss this point in the next slides. Then another function is excitation contraction coupling. You know, in skeletal muscles as well as in smooth as well as in cardiac muscles, that when first there is an action potential, then it will depolarize the membrane and through the T tubules it enters deep inside the muscles and it causes the release of calcium. In case of skeletal muscles, it causes the release of calcium from sarcoplasmic reticulum, and when there is more calcium inside the cytosol, this will stimulate the contraction. Also in smooth muscles and cardiac muscles, when action potential arrives, this will cause opening up of the voltage-gated calcium channels on the membranes and increased calcium will enter inside. So whenever cytosolic calcium increases, this will increase the muscle contraction. So we are talking about, answer to your question, we are talking about two different sources of calcium. If cytosolic calcium increases, this increases the likelihood of contraction. But if extracellular fluid calcium, if it is increasing, it is decreasing the neuromuscular excitability and it is decreasing the likelihood of contraction in the muscle. So this is the difference. And also stimulus secretion coupling, you have studied, or no, you will study in the nervous system module, or you have studied neuromuscular junction, right, in muscle physiology. So you know when in the presynaptic nerve terminal, when the action potential arrives, what is the next step?
Exocytosis.
Exocytosis of or neurotransmitter. But before that, what is required? Huh? Yeah, opening up of the calcium channel. When the action potential arrives at the presynaptic nerve terminal, this causes opening up of the voltage-gated calcium channels. Calcium moves inside, and this causes exocytosis of the secretory vesicles, and acetylcholine is released out. So this process is stimulus secretion coupling. And also excitation secretion coupling is the process which happens in insulin secreting cells, pancreatic beta cells, that when they are stimulated, the calcium enters inside and this causes the release of insulin from them. And also, you have studied the blood. No, you will study next. You will study hematology, so you will come to know about the clotting mechanism. So in the blood, we have different type of clotting proteins which are not active, and for their activation, we require calcium ions. So if calcium is present, then it will cause activation of the clotting factors. And if calcium is removed from the blood will not be able to clot. So these are the functions of the calcium in our body. So blood calcium must be controlled because low plasma calcium increases neuromuscular excitability and high plasma calcium decreases neuromuscular excitability. And plasma calcium behaves differently from cytosolic calcium, the question that you asked. Okay, so what happens? You have studied in neuromuscular physiology that if there is increased neuromuscular excitability and the muscle will be stimulated again and again, then the calcium gets so much accumulated inside, it is not going back to the sarcoplasmic reticulum and it is increasing in amount. So this will lead to sustained contraction in the muscle, spasm. What is this in Arabic? Tashannuj, yes. So sustained muscle spasm, and if the respiratory muscles get affected, you have studied respiratory physiology, right? So in the main respiratory muscle is diaphragm. So in the process of breathing in and breathing out, the diaphragm muscle is contracting and relaxing periodically. So you need relaxation as well as contraction. But if the diaphragm muscle is affected by this and there is continuous sustained contraction of the diaphragm muscle and there is no relaxation, then the breathing will be affected and this will be asphyxia and death. So this can result from hypocalcemia. Okay, so in calcium metabolism, there are two terms, calcium homeostasis and calcium balance. When we say calcium homeostasis, we are referring to the regulation of free form of the calcium in the blood, and this is done on minute-to-minute basis. Every second, the free form of the calcium is regulated and maintained through the exchange of calcium between the blood and the bones, because bones are the storage house for the calcium and 99% of the body calcium is present there. So this exchange between the bone and the extracellular fluid is taking place every second so that the calcium is maintained at a normal level, and this is done through the parathyroid hormone. And when we talk about calcium balance, that means keeping the total amount of calcium in the body normal. In the total amount, we means the calcium present in the bone as well as in the other soft tissues. So the total amount of calcium regulation is known as calcium balance, and just the free form of the calcium regulation is known as calcium homeostasis. And calcium balance is maintained by controlling the degree of absorption and degree of excretion of the calcium. You have studied the aldosterone hormone, right? It is regulating the sodium and potassium metabolism. But the regulation of sodium and potassium metabolism, it differs from the regulation of calcium in some aspects. For example, in calcium you have storage site, reservoir in the body. Do you have a reservoir for sodium and potassium? No. Also, what is the function of aldosterone on sodium and potassium? It reabsorbs sodium and excretes potassium. Do you have any hormone which is controlling the absorption of sodium and potassium from your digestive system? Sodium and potassium. No. So for sodium and potassium, you have only control on hormonally control on their excretion, degree of excretion. But for calcium, you have a hormone which can control the amount of calcium which is absorbed from your food. Which hormone?
Vitamin D.
Vitamin D. So in this way, the calcium metabolism differs from sodium and potassium. So the free form of the calcium in the blood, it is maintained through by three organs. One is the bone, then intestine, and the kidneys. So through the bones, we can mobilize the calcium freely from the bones to the extracellular fluid or from the extracellular fluid into the bones. And this is important for calcium homeostasis. And in the intestine, we have a hormone, vitamin D, which can control the amount of calcium which is absorbed. And also through the kidneys, we can have harmonically control the amount of calcium which is excreted or which is reabsorbed. And this is important for the calcium balance. And all of these processes, the mobilization between the bones, absorption from the intestine, and reabsorption from the kidneys, they are under the control of hormones. And there are three hormones that regulate calcium metabolism. Parathyroid hormone, 1,25-dihydroxycholecalciferol. What is this? Yeah, this is the active form of the vitamin D. And then calcitonin. Parathyroid hormone, in addition to controlling the calcium, it also lowers the phosphatase. Where they are located, parathyroid glands, paramine adjacent. So parathyroid, they are adjacent to the thyroid gland, and look at the size. They're very small, very minute, and circular structures which is present posteriorly to the thyroid gland. So there are 1, 2, 3, 4 parathyroid glands. So the main function of the parathyroid hormone is to increase the blood calcium level, and it acts on the bones, kidneys, and intestine. How we will see on each organ, what is the effect of parathyroid on the bones, what is the effect on kidney, and what is the effect on intestine. So from the bone, it causes the mobilization of calcium stores. It causes the removal of calcium from the bones, and there are two processes through which it can do so. There is a fast exchange process and there is a slow exchange process. So both these processes, fast exchange as well as slow exchange, they will be stimulated by parathyroid hormone. In case of fast exchange or fast calcium efflux is outward movement. So the process by which calcium moves out of the bone fastly, it is the removal of calcium from the bone fluid. So we will see next slides what is meant by bone fluid. So bone fluid is also, from the bone fluid we can remove the calcium, the parathyroid hormone can remove the calcium, and it is the rapid exchange, fast exchange. And then parathyroid hormone can also remove the calcium from the stable pool, which is through activation of bone breakdown, through activation of osteoclasts. So there are two processes by which parathyroid hormone removes the calcium from the bone. One is the fast process, the other is the slow process. So this is, you have studied the structure of the bone in histology or anatomy. What is the structure and functional unit in the compact bone? Huh? Yes? Osteon. I'm not asking about the cells, I'm asking about the structure and functional unit.
The Hammerstein system.
Yes, it is osteon in the Hevesian system. It is osteon. What is present in the center of the osteon? Central canal. Okay, this is the central canal. And what is surrounding the central canal? You have concentric layers, lamellae. Yes, you have concentric layers of lamellae. And these lamellae, they are containing in within them, these cells which are osteocytes and osteoblasts. Okay, so this is the magnified view. You can see these osteocyte cells. So this is the magnified view. This is the central canal in the center of the osteon, and this is surrounded by concentric layers, lamellae, in which you have osteoblasts and osteocyte cells. And they are arranged in such a way that the layer which is just close to the central canal, this is having osteoblast, and the layer which is the outermost layer, it is also having osteoblast. And in between them, there are layers of osteocytes. So osteoblast cells are arranged just next to the central canal, and another layer is the outermost layer. In between are the osteocyte cells, and they are arranged in such a way that they are forming cytoplasmic extensions. There are extensions or there are processes from one osteocyte cell extending towards the adjacent neighboring cell, and then the neighboring cell is forming the cytoplasmic extensions which are extending to the next neighboring cell. In this way, you can see as if it looks like that they are joining, shaking hands. One osteocyte cell is shaking hands with the adjacent osteocyte cells. And where they come, the two cytoplasmic processes, where they come close to each other, there are gap junctions between them. So one osteocyte cell is connected to the neighboring osteocyte cell through these arm-like extensions, and there are gap junctions in them. What is the significance of gap junctions? Communication, because gap junctions offers very minimum resistance to the flow of ions, so that means ions from one osteocyte cell can freely move to the next osteocyte cell. So in this way, all the concentric layers or lamellae, in these layers, the osteoblast as well as osteocyte cells, they are linked to each other and they behave as a membrane, they behave as a unit. And this is known as osteoblastic membrane. So these osteoblasts and osteocytes, they are actually lying in a cavity which is filled with the fluid. So these cavities, they are called canaliculi, and there is fluid in them. This fluid is called bone fluid. So in this picture, you can see these dark brown cells. These are all osteocyte and osteoblast cells, and you can see these light brown color surrounding them. So this is the area, canaliculi, which is having bone fluid, and outside them there is very white color area, and this is the mineralized bone. Okay, so the parathyroid hormone can cause removal of calcium from this bone fluid into the osteocyte cell, and then through the gap junctions, these calcium ions move to the next neighboring cell, and then finally to the osteoblast cells, and through this the calcium will diffuse into the central canal blood. So this is the fast exchange, and it is done by stimulation of calcium pump. In the osteocytes membranes, there are calcium pumps. So the parathyroid hormone will stimulate these calcium pumps. So when these calcium pumps are stimulated, they will open. So the calcium will be removed from the bone fluid, and it will enter in the osteocyte cell, and then from one osteocyte to the next, till it diffuses to the central canal. This is called fast exchange of the calcium. So here is the same concept. This pink color is showing the blood in the central canal. This dark brown color is showing the osteocytic osteoblastic membrane. All the cells, osteocytes, osteoblasts, which are connected to each other through gap junctions, and they are behaving like a single membrane. And this light brown color, this is the bone fluid. So when the calcium is removed from this bone fluid, it first diffuses into the osteocyte cells, and then it diffuses into the plasma. This is fast exchange or rapid exchange. And in the slow exchange, what happens, the osteoclast cells, which are the bone-eating cells, they are stimulated, and when they are activated, they will eat or they will break the bone, the mineralized bone, which is this part. So when this bone is broken down, then the calcium as well as phosphate ions, they are released. They will diffuse into first into the bone fluid and then into the osteocytic osteoblastic membrane and then into the plasma. So this process is the slow exchange. It takes time. So immediately in minute to minute basis, whenever there is a drop in the plasma calcium levels, then through fast exchange process, the parathyroid hormone will stimulate the calcium pumps and the calcium will be removed from the bone fluid into the blood plasma. But if there is the magnitude of hypocalcemia is bigger and the bone fluid is not sufficient to compensate for this, then the osteoclast cells are also activated and this leads to slow exchange of calcium. So both these fast exchange as well as slow exchange, they are stimulated by parathyroid hormone. It is similar to the bank system. You all have bank accounts, right? No? So when you want to withdraw the money, you have two options. Either you go to the ATM or you go to your bank, right? So what makes you to decide whether you want to go to the ATM or you should go? Time. Time. Which one is faster? ATM is faster. So if you need quick, fast money, so you go to the ATM. You do not go to the bank because you know the bank will take time, and from the ATM it is immediate. Another factor which can affect your decision: how much the amount. How much can you take out in one day from ATM? 5,000. Oh, same for us.
No, 5,000.
That is same for all the ages. For all the age, whether you're young or old, it's just 5,000 for everyone. Yeah, okay. So if you want to buy a car or anything else for which you need more money, so you will go to the bank. Okay, so the speed, whether you want it immediate or you want it more, quickly, this as well as the amount. This helps you to make the decision whether you need to go to the ATM or to the bank. So in the same way, when the body needs calcium immediately, fast, and the amount of calcium is small, it will be removed from the bone fluid. But when the amount of calcium that is required is more, then it will need the help from the osteoclast cells to remove the calcium from the stable bone pool. Yes?
Doctor, the slow exchange, does it also use the membrane-bound calcium pump, or is that just for the fast exchange?
It will also use the yes, because when the osteoclast cells, when they are activated, they will break down the mineralized bone. So the calcium and the phosphorus, they will enter the bone fluid. From the bone fluid to enter into the osteocytic osteoblastic membrane, the calcium pumps are there.
And it requires ATP as well.
Yes, because they are active. Okay, so this was the action of parathyroid on the bones. Next we move to the action of parathyroid on the kidneys. It will cause the kidneys to reabsorb calcium and to remove phosphate ions. So calcium will be reabsorbed, phosphate will be excreted, and also it will cause activation of vitamin D. So there are three functions of parathyroid hormone on the kidneys. And on the intestine, it will cause the absorption of calcium from the food, but this absorption of calcium as well as phosphate from the intestine, this is done indirectly by parathyroid hormone because there are no parathyroid hormone receptors on the intestine. It is actually the vitamin D which will perform this function. And since for the activation of vitamin D, you require parathyroid hormone, so we say that this is an indirect function of parathyroid hormone. So what is the overall effects? It will mobilize the calcium from the bones, it will conserve the calcium from the kidneys and excrete phosphate. And also it will cause absorption of calcium from intestine through vitamin D. So as the net effect, blood calcium will increase and phosphate will decrease. So we say that parathyroid hormone is a hypercalcemic and hypophosphatemic agent. Like aldosterone, it is also essential for life, and if it is completely absent, it will cause death in just a few days. Control of parathyroid hormone secretion, the blood calcium level. If the blood calcium level decreases, this will stimulate the release of parathyroid hormone, and if the blood calcium level increases, this will inhibit the release of parathyroid hormone. This is the summary of the functions of parathyroid hormone on kidneys, bones, and intestine. Another hormone which can affect the calcium metabolism is calcitonin, and it is released from thyroid gland. In the thyroid, you have follicular cells and parafollicular cells. The parafollicular cells will release calcitonin, and it is a hormone which antagonizes the parathyroid hormone. It has functions which are just opposite to the parathyroid hormone. So if you know the functions of the parathyroid hormone, you can yourself tell what is it. So parathyroid hormone is causing mobilization of calcium from the bones. So calcitonin will inhibit this process, and parathyroid increases the blood calcium level. So calcitonin will lower the blood calcium level. It does so by decreasing calcium movement from the bone fluid, that is fast exchange. Also, it inhibits the bone resorption by inhibiting the osteoclast. So both processes, fast exchange as well as slow exchange, they are inhibited by calcitonin. But the role is not important for calcium metabolism. And if this calcitonin increases in the body or it decreases, it does not have any effect. It is not so important. Okay, what happens when the patient will have high levels of parathyroid hormone, hyperparathyroidism. So if you know the functions, you know the function of the parathyroid hormone is to increase the blood calcium. So if the parathyroid hormone levels are high, what will happen to the blood calcium levels? Will increase hypercalcemia. What will happen to the neuromuscular excitability? It will decrease because you know it is inversely proportional. So if there is hypercalcemia, neuromuscular excitability will decrease. So if there is less excitability, the neurons, the patient will be feeling fatigued, exhausted, less mental activity, less arousal, less alertness, and if there is decreased excitability of the muscles, the patient will be having just a weakness, and also cardiac disturbances may occur because of the hypercalcemia. And when the parathyroid hormone levels are high, it is causing removal of calcium from the bones. So what will happen to the bones? Hmm? Don't say osteoporosis. We will see in the next slides what is decreased bone density. Yes, bones will get demineralized. The calcium and phosphate will be removed, so they will become weaker. Thinning of the bones, and pathological fractures can occur. And what happens if there is hypercalcemia in the blood? More calcium will be filtered into the kidneys. So stone formation. Kidney may inside the kidney there may be calcium stone formation, and these stones are very painful. If a stone gets dislodged, detached from the kidney and it enters the ureter, it is extremely painful for the patient. So also hypercalcemia can cause peptic ulcer. So there is a saying to remember the hyperparathyroidism effects. It says bones, stones, abdominal groans, and moans. So bones means that hyperparathyroidism is affecting the bones, and the bones get thin out, weaker, bone pains, and pathological fractures. Stones mean that kidney stones are common because of hypercalcemia. Abdominal pains because of hypercalcemia, there may be peptic ulcer and other types of pains. So these are the and hyperparathyroidism, what could be the causes of hyperparathyroidism? It could be primary or secondary. Primary is when there is a tumor in the and what is secondary? Huh? Where? Huh? What are the causes of could be causes of secondary? Yeah, he's right. How vitamin D deficiency can cause secondary hyperparathyroidism? How?
Well, it decrease, so we cannot absorb calcium.
Yes, decreased vitamin D will lead to decreased calcium in the blood. So decreased calcium is a stimulus for the release of parathyroid hormone. So, okay, so vitamin D deficiency. Any other cause?
Chronic renal failure.
Very good. Chronic renal failure. Because vitamin D is activated in the kidneys. So if kidneys are damaged, the vitamin D will not be activated. So chronic renal failure and vitamin D deficiency are the important causes of secondary hyperparathyroidism. Oh, there are answers already in front of you. So what will be the levels of falling in a patient with primary hyperparathyroidism? So serum calcium will be high, right? It's a primary. So parathyroid gland is producing more parathyroid hormone. Serum calcium would be high. Serum phosphate would be low because parathyroid hormone causes the phosphate to excrete from the kidneys. So plasma or serum phosphate will be low. Urinary phosphate will be high because more of it. Urinary calcium will also be high. Why?
When it exceeds.
So more.
Yes. Good. This is from renal physiology. When you, like in hyperglycemia,
Renal threshold.
yeah, for like when you are having any like when any chemical increases in the amount it increases in the blood, then when it goes to the kidneys, more of it will be filtered. So when there is more calcium in the blood, more of calcium will be filtered in the kidneys. So the filtered load of the calcium for the kidneys, it will increase. But there is a threshold, like in case of glucose, there is a renal threshold. Renal tubules can reabsorb glucose up to a limit. After that, they get saturated, so glucose start appearing in the urine. So in the same way, for the calcium reabsorption also, there is a limit for the kidneys. So when they get saturated, the calcium starts appearing in the urine. So urinary calcium will also be high. And urinary cyclic AMP. Cyclic AMP, which type of hormone is parathyroid hormone? It's a peptide or it's a peptide. So it uses which second messenger? It uses second messenger, right? So second messenger here is the adrenylase cyclase AMP. So cyclic AMP will increase when the parathyroid hormone levels increases. It acts on the renal tubules and it leads to the more formation of cyclic AMP. So more cyclic AMP will be present in the urine. And alkaline phosphatase level, they are also high. What does they tell when in the blood alkaline phosphatase level increases? Bones and yeah, it's one of the indications that there is damage to the bones. So because of this parathyroid hormone causing stimulation of osteoclast cells and bone breakdown, the alkaline phosphatase level increases. So this is the case in primary hyperparathyroidism, which will change in if it is a patient he is having secondary hyperparathyroidism. So what will happen to the serum calcium level?
No, decrease.
Yeah, it could be decreased or normal, but it will never be high.
Why? Increase.
In secondary hyperparathyroidism, what will my question was in secondary hyperparathyroidism? This we said this is in primary hyperparathyroidism. So if the patient is secondary hyperparathyroidism, he's not primary, he's not having a tumor in the parathyroid. If he's secondary hyperparathyroidism, so what will be the serum calcium level?
Why decrease?
Why decrease?
No vitamin D to enhance its absorption.
Okay,
Okay,
parathyroid will increase.
osteoclast activity causing osteoclast.
Yeah, but what is the stimulus for the release of parathyroid hormone? It is hypocalcemia, which is causing the release of parathyroid gland, parathyroid hormone. So parathyroid hormone will act on the bone fluid and on the osteoclast cells to increase the calcium levels. So calcium levels, initially hypocalcemia, it can improve, it can come to the normal, but it will not increase because when it comes to the normal, the parathyroid hormone secretion will stop, right? Because hypocalcemia was the stimulus. So you will never find high plasma calcium in secondary hyperparathyroidism.
So there is no hypocalcemia in vitamin D deficiency.
There is hypocalcemia in the vitamin D deficiency, and by parathyroid hormone, it may bring it closer to the normal, but initially it can bring it to the normal, but if the vitamin D deficiency continues, you have limited stores. Like how much calcium the parathyroid hormone can be removed. Parathyroid hormone can be removed from the bones, right? So you have to diagnose it early and you have to give vitamin D to the patient. Okay, in hypoparathyroidism, the symptoms will be opposite. There will be hypocalcemia and hyperphosphatemia, and you know that if there is hypocalcemia, there will be increased neuromuscular excitability, and it can lead to sustained muscle spasm and tashannuj, which is tetany, and spontaneous generation of action potential, and it could be tetany, right? So death may result from respiratory failure, and this is the sign. which is known as carbohydrate spasm. So if there is hypocalcemia, one of the sign is the Shostak sign, and this is the carbohydrate spasm. It is done by Trousseau sign. Have you done this in clinical skills lab? Trousseau sign. He's saying yes, you are saying no. Okay, so in Trousseau sign, you wrap the blood pressure cuff around the arm and you inflate it above the systolic blood pressure. So this stops the blood flow through the arm. So what happens when the blood flow to the muscles is stopped? The sodium, the energy, the oxygen supply decreases, so ATP decreases, and this stops the activity of sodium-potassium pump, which was supposed to maintain the resting membrane potential and the neurons. So when sodium-potassium pump fails inside the nerves, the positivity will increase. So the membrane threshold, it comes closer to the resting membrane potential, it comes closer to the threshold potential, and it becomes easier to excite it. So now the patient have two stimuli for increased neuromuscular excitability. One is hypocalcemia, and other you have created ischemia and inhibition of sodium potassium pump. So in this condition, the patient will develop this type of spasm, which in the technique. And also the hyperventilation. If a person hyperventilates, what happens to the carbon dioxide levels in the blood? Decreases, because he is hyperventilating, he is removing more carbon dioxide. So the carbon dioxide amount in the blood will decrease. So decreased carbon dioxide amount in the blood, it will increase the protein binding of the calcium. So more calcium will bind with the proteins, and it will become difficult for the calcium to detach from the protein. So a hypocalcemia will be created. So this can also lead to tetany. This is another case. Mona is a 24 months old girl. She has failure to thrive. Failure to thrive means failure to grow, not like normal children, and an unusual gait. Gait is the way she walks. She also has bored legs. Bowing of legs means curved legs. Thick wrists and dental caries. What is dental caries? Yes. Her weight is 8 kg and height is this. They are below normal. Her diet consists predominantly of breastfeeding 5 times daily. So this is abnormal. Predominant breast. A child who is 24 months old, almost 2 years, he should be taking solid food, not the predominant breastfeed. And the breastfeed is a very poor source of vitamin D. So if you get a case scenario in which there is a child 2 years old, or he is predominantly taking breastfeeding, that means he is suffering from vitamin D deficiency. The patient's antenatal delivery and postnatal history are unremarkable. So this you can see the curved legs. This is called bowing of legs or curved, and thickening of the wrist. So these bony deformities, they are common in vitamin D deficiency in the children. Yes?
Breastfeeding lead to vitamin D deficiency.
Yes.
Why?
Because the vitamin D is not present in the breast milk. It's a poor source. What is the source of vitamin D? Huh? Dietary source of vitamin D. It's milk and dairy products, but the breastfeed is not a good source of vitamin D. Even the dairy products, the more strong source of vitamin D for us is the skin. So what is going on with the Mona? So she might be having the deficiency of vitamin D. What is the role of vitamin D? It increases calcium absorption from the intestine, and also it increases the number of receptors for the parathyroid hormone on the bones. So it increases the responsiveness of the bone to the parathyroid hormone. So this is the function of the vitamin D. And remember this, that in chronic kidney failure, the patient may have vitamin D deficiency, and also in parathyroid hormone deficiency, like hypoparathyroidism, the patient may develop vitamin D deficiency. Why? In hypoparathyroidism, the patient may develop vitamin D deficiency. Why?
Because negative feedback.
The kidneys will not transfer the
Yeah, we will learn in the next slides.
From calcium
So
dioxide.
activation of vitamin D. For the activation of vitamin D, the vitamin D which you take from the diet or the vitamin D which is present in your skin, it is not active. It has to pass through certain steps, biochemical changes. One, it will take place in the liver, and then the last step takes place in the kidneys. So that last step of activation in the kidneys, it requires parathyroid hormone. That enzyme requires parathyroid hormone. So if parathyroid hormone is deficient, the vitamin D activation in the kidneys will also be defective. So this will lead to vitamin D deficiency. So active vitamin D is synthesized in skin, liver, and kidney. So this is the picture. It is showing you that if the skin is exposed directly to the sunlight, then the precursor form of vitamin D in the skin, it will change into another form, which is vitamin D3. Also the dietary vitamin which is present in the milk and dairy products like cheese, etc. It is also in the form of vitamin D3. So it goes to the liver and it gets converted into another form, and then it goes to the kidneys where it gets converted into the final active form, which is 125 dihydroxy vitamin D. So parathyroid hormone will stimulate this stuff. So deficiency of vitamin D will decrease the absorption of calcium from the diet. So this will lead to a disease which in children it is known as rickets, and in adults it is known as osteomalacia. So what do you expect to find in Monar's blood investigation? She's having vitamin D deficiency, so the plasma calcium levels will be low, hypocalcemia. But about the phosphate levels? Hypophosphatemia, because vitamin D is causing absorption of calcium as well as phosphate from the intestine, so both will decrease. Parathyroid hormone? Parathyroid hormone increase. Parathyroid hormone will increase because hypocalcemia will stimulate the release of parathyroid hormone. This is the summary of the parathyroid hormone, calcitonin, and vitamin D. Now we move to the osteoporosis. So osteoporosis is weakening of the bones because of the age. It is age related, and osteo means bone and porosis means porous. The bones become porous. There are holes produced in the bone, and there is reduction in the bone mass by 50 to 60 years of age. Exact cause is not known. There are different hypotheses. One of the hypotheses is that after the age of 50 to 60 years, the osteoblast activity decreases and osteoclast activity increases. So the bone breakdown process becomes greater than the rate at which new bone is formed. So as a result of which the bones become porous due to reduced osteoblastic activity or increased osteoclastic activity. And it occurs more rapidly in women after the menopause. Because, yes, estrogen, what does estrogen do? Estrogen stimulates the osteoblast, the bone forming cells. So if estrogen levels are low, the osteoblastic activity decreases. But the blood calcium levels, parathyroid hormone levels, and the phosphate levels, they are normal in osteoporosis. This differs in case of primary hyperparathyroidism or from osteomalacia. If it is hyperparathyroidism, in hyperparathyroidism, these parathyroid hormone levels will be high. Calcium levels will also increase if it is primary hyperparathyroidism. Then calcium levels will also increase, phosphate levels will decrease. But in osteoporosis, these levels are normal. This is the normal bone in a normal person. And this is the bone of a female at the age of 88 years. The previous one was at age of 30. So look at the structure, and here this is at the age of 88. So the holes, the size of the holes have increased. So whatever bone is present, whatever bone is left, it is normal. It is normal composition. It is having normal ratio of the bone minerals and bone matrix in osteoporosis. But in rickets or in osteomalacia or in primary hyperparathyroidism, the composition of bones changes. It becomes abnormal. The composition becomes abnormal because the minerals, bone minerals are removed. Calcium and phosphate has been removed. But in osteoporosis, The amount of the bone is less, but whatever bone is there, it is normal in structure. But the patient have less of it. So this is all about the calcium metabolism. So I will open the quiz, and this was the last lecture. So all the best for your exam and all the best for your future. May you all become very successful physicians and success idea for your parents and for us, your teachers. Okay? All the best. Okay, the quiz is open now. You can do.